Now we have very interesting topic by Dr. Zamurrud Patel. She is the HOD and Chief Consultant Dietitian at Glengale's Hospital, Patel, Mumbai. Her major achievements are she has received Sadhana Award for Clinical Dietetics and Florence Nightingale Award for Therapeutic Nutrition in 2025, Distinction Award for Excellence in Nutritional Practice, Quality Award for Excellence in Medical Nutrition Practice and Quality Award for Excellence in Public Nutrition 2025. Her publications are multiple, and may I call upon Dr. Zamurrud Patel to deliver?
Thank you.
Thank you.
So good evening. Firstly, I would like to thank the previous speaker for covering many things for me beautifully. Dr. Manish, thank you very much. And the question that was asked by the person, so probably storing the rice and eating or storing the potatoes and eating, the starch gets converted into resistant starch, and that is why the absorption and utilization varies. So that was the answer to that. So the topic given to me is medical nutritional therapy in diabetic kidney disease or diabetic nephropathy, the real world case scenarios, and I would be genuinely presenting to you the cases that I have dealt with over my journey. So to start with, I would start with what is diabetic kidney disease, and probably it's one of the complications when diabetes is not controlled well. So if you look at the symptoms, it starts with proteinuria. There is progression of the disease when the proteinuria extends further. The glomerular filtration rate drops, and probably there is the arterial blood pressure that gets elevated. So talking of the pathogenesis of diabetic kidney disease. So basically when you have uncontrolled sugars, probably you can see that how proteinuria sets in, the afferent arteriole gets dilated, increasing the intraglomerular pressure, which causes proteinuria. And probably if this is not controlled over a period of time, people progress. So you can have diabetics with proteinuria and then frank diabetic nephropathy or diabetic kidney disease. So probably if you follow the previous speaker's advice, Dr. Manish, people will not come here, right? You did it beautifully, and it basically covered all the aspects. Today people are talking of Mediterranean diet, people are talking of DASH diet. Nobody is talking of the cultural Indian diet. India predominantly is a nation which is vegetarian. So probably that really helps us. Sorry, the slide is not changing. No, sorry. Okay. So talking of the various stages, what happens exactly in diabetes. So we've already explained that. Initial stage, there is hypertrophy of the renal tissues, probably increasing, going stage wise, and over a period of time how it progresses towards end stage. So there are stages given, stage 1 to 5. So I am not getting into the medical part to it, but basically what I am trying to emphasize is that probably in the early stages, if you follow the dietary advice, control your sugars well, and probably diabetes is a package deal. You know, with diabetes you need to control your pressures well, you need to control your weight well, you need to control your lipids well. So if this package deal is taken and it's taken care, probably you can help the patients better. So in the early stages, a good glucose control will prevent glomerular hyperfiltration, which is an important role. It has a very important role in the pathogenesis of diabetic kidney disease or diabetic nephropathy. And in the later stages, when the number of nephrons reduce, probably there we really need to look at the protein intake. Why am I talking of protein intake in diabetic kidney disease? Because today if you read literature, for diabetics probably we are trying to give more protein, and we are counseling our diabetic patients to eat little more protein because you want to reduce the calories coming from carbohydrates. And probably in that population, if you evaluate them well, and you can really prevent what I really explained earlier. So when the number of nephrons are reducing and you try to reduce the protein intake, probably you can prevent the progression of the disease. But again, having said, from morning we are listening about malnutrition, sarcopenia in this population, and probably you really need to work very well when it comes to protein in this population. So how much protein restriction is needed? Okay. So what actually I am trying to show you is, I'm sorry, the slides move here but it doesn't move there. Okay. So how much protein should be restricted? So probably what we need to do in our diabetic kidney disease patients is, we have been looking at a protein intake of 0.6 to 0.8, but you also need to look at the quality of protein that you are giving. So you have to give at least minimum 50% should be of high biological value. Probably a few of these diabetic kidney disease who have a very good appetite, who have a very good nutritional status, you can further reduce the protein and use supplemented very low protein diet taking help of keto analogs. But mind you, you need to understand when you are picking the patients, it's very important that you have to do the assessment. Now somebody was talking in the morning about keto analogs. These are not basically pills or drugs. These are not magic bullets. Basically keto analogs are deaminated essential amino acids. I have been using them, but when I have been selecting my patients, I really take my nutritional care process into account and then decide whether the patient needs it or no. Since these keto analogs do not contain nitrogen, they do not generate nitrogenous waste products. At the same time, they are acceptors of the amino group from the urea generating non-essential amino acids, and in this process get converted into essential amino acids that are needed by our patients. So probably if somebody has a very good appetite, a good nutritional status, probably diabetics we know are obese. So probably you can look at that and then you can use this therapy. Of course, having said that, you have to also understand that, again I repeat myself, this is not a magic bullet. It is just one therapy that you can use for your patient and see whether the patient is actually getting the benefit or no. If the patient is not getting benefit, the patient is not able to adhere with your dietary prescription, probably you can withdraw. Further, the last point that I have put, these keto analogs contain calcium content of keto analogs are better in the preparation, and again their phosphate binding capacities allows for a better correction of the mineral metabolism. So that is why probably you can look at that aspect also when you are prescribing keto analogs. So how should keto analogs be used? You have to first do your selection of the patient. Everybody does not require protein restriction. Mind you, many a times when actually we do an assessment of our patient and we find that the patient is already eating 0.4 gram of protein and the patient does not have an appetite, probably we add the keto analog. We have been using, but we do give adequate amount of calories, and the recommendation that we have been using is 1 tablet per 5 kg of body weight. So when I said that we really look into the protein intake of our population, our patients, I have been doing the 24 hours urea nitrogen appearance for the patients to calculate. This is a very good method of calculating the protein intake. As nutritionist, I always do the diet diary and a 3-day recall and a 7-day recall. Probably if you see, most of my patients keep a diet book. They keep writing whatever they eat throughout. So it really helps them also and us also to calculate the calorie and the protein. But this is also one of the very good method which really helps me to estimate whatever diary they have written, how we can match it and we can see. Because in a stable patient, nitrogen intake and nitrogen output is going to be equal. And if I tell you the amount, 1 gram of nitrogen is equal to 6.25 grams of protein. So if I calculate it that way, I can get the protein intake of my patients. So use of low protein diet in clinical practice, yes, there is lot of literature that is showing us that you can use low protein diets, but it must be realized that each patient is different. So today if you see the latest guidelines, they all say that diet needs to be individualized, your prescriptions for your patient needs to be individualized, and based on that, because each person does not have the same disease, though they are labeled as kidney patients, each person's disease is different, their appetite is different and their nutritional status is different. Again, keto analogs are expensive, of course we all know it, and so you have to use it judiciously. Just to show you little on the literature, I have not put much on the literature, just to show you that dietary protein restriction helps in the progression of diabetic kidney disease. This is just to show you, but how much to restrict is again something that you really need to pay attention. And when you are restricting the proteins, are you meeting your targets for energy intake? That's very important, because when you restrict one nutrient, whether it's a micronutrient or a macronutrient, other nutrients get affected, intake gets affected. So it's very important that we pay attention to the overall. So when I have to see a patient with diabetic kidney disease, first thing that you see is my distribution of energy that will come, and Dr. Manish beautifully explained simple carbohydrate and complex carbohydrate. So here in this population, probably complex carbohydrate you can go as high as 70% of your energy coming in from complex carbohydrate. Probably that will also help in achieving your target of your fiber, which is 25 to 30 grams for your patient. Again, talking of fat, fat is not bad for our population. You need to give the right quality of fat. So when you are giving fats, almost 25 to 30% of energy can come from fats, but you need to look into the quality of fat rather than the quantity of fat. And of course, proteins, we have already spoken, what you require you can give. Again, recommendations from various bodies are there which tell us, we have already seen from morning all the recommendations, so I am not getting into the detail, but probably looking at diabetic kidney disease, keeping a protein intake between 0.6 to 0.8 and assessing and reassessing is something that you really need to do. These are again guidelines. Why I kept this guideline purposely was for the energy intake, not so much for the protein intake. See, a normal person requires around 30 to 35 kilocalorie per kg body weight per day. Even a kidney patient requires that much amount of calories. There is no compromise on calories in this population. Even in diabetic kidney disease, probably you may not go as high to 35, but you will if your patient is obese, but still you need to give him adequate 30 kilocalories, you will need to give it to him. And probably if you start planning in this order, you will not have a problem. So when you are selecting your patients, you really need to pay attention to that if a person, most of the time diabetic kidney disease comes with massive proteinuria. So these people are not the right candidates where a supplemented very low protein diet may be used. Probably you just need to keep them in low protein. Probably even if I am talking in an Indian context, I am still using the term low protein diet, because if I say I am giving normal protein, my patient does not understand that, right? So you have to need to know this, and you definitely need not give the same prescription to all patients. If somebody has no appetite, if there is some active other disease which is there, or probably any other severe organ affected, probably diet is going to change. You are not just going to focus on giving a low protein diet. So how do we do it? We basically, I follow the nutritional care process, my A, B, C, D, E. Now I have added E to this, where A is my anthropometry, B is my biochemical, C is my clinical picture, D is my dietary assessment, and E is my exercise. So I look into all these parameters, do the baseline calculations, do the 24-hour study, and be sure when it comes to the proteins, and then we start prescribing patients. So now coming to my first case. This is a 55-year-old female who has been having diabetes and hypertension for last 10 years. She has a proteinuria of 500 milligrams. Her creat is about 1.5, sodium is normal, GFR is good enough. So just going to her next, her height is 150, and for a female of height 150, the ideal body weight should be about 50. She is 65 kilos. She is a vegetarian using cow's milk, and her recall is showing me around 1900 calorie, 51 grams of protein. It correlates well with her nutritional status. And the 24 hours test also is showing me a protein intake of 50 grams per day. So the diet diary and the urea nitrogen appearance method is showing me a similar type of protein intake. So what is the thought process that one has? So this is basically, if you ask me, almost a low protein diet, 0.8 to 0.9 grams she is taking. So what would be the thought process? Is this patient, can we modify something to do with the proteins? Probably the answer should be, at least what I have tried is yes. I have used a supplemented very low protein diet with keto analogues. Again, as I showed you the previous slide, I take a lot of counseling to the patient to give them that you have to eat adequate calories. I am just bringing down your proteins, and I am giving you a tablet form keto analog that you have to take. So probably here the protein went down to almost less than 5% because I have reduced the proteins there. And believe me, this person is doing well. It's because she had some extra weight, but when I did this, her calorie requirement was kept to 30 kilocalories per kg per day. We have not got that down drastically. Okay. So, regular monitoring is very important for compliance. Probably just counseling them once, giving them the prescription does not help. You need to counsel, recounsel, recounsel, recounsel. And it's not the counseling only for the patient. This counseling or nutrition education is for the caregiver also, because sometimes the patient does not want to follow, the caregiver is always there to support. Coming to the second case, this is a 65-year-old diabetic hypertensive male who has everything. He is having some infection, he has heart problem, he has lost interest in eating. Okay. Now, if I show you the investigations, the hemoglobin is low, the albumin is low and the creat is also low, right? But he has multiple issues and he is not able to eat, and if you see his weight is 50 kilos for a height of 165 centimeters. For a male, the ideal body weight should be around 65 kgs. Now, what do you do with such a case? Do you prescribe a low protein? Do you prescribe a supplemented very low protein diet? I don't think it is right. What I would first do is no diet restriction. I want my patient to start feeling good and start following his actual diet pattern. But having said that, you don't just give that prescription and leave. No. You need to keep the treating physician with you, telling them what is being done, what are your findings from the assessment, and based on that sit with your physician, take whatever guidance you are giving, only then this works. So I just wanted to show you two slides. This is from the MDRD trial. The MDRD trial clearly showed us that with a increase in your serum creatinine, a decrease in your GFR, probably there is a spontaneous reduction without even advising patients to reduce their intake. So probably even if you see from this the staging of BMI in chronic kidney disease, as the disease progresses, the nutritional status is going low. So probably people who have a bad appetite, they are not able to eat. For these people, giving them any form of restriction may be not the right thing. But having said that, that does not mean you tell them eat everything and you just leave them. No, you need to again reassess them and see if their appetites are getting better. Probably you need to again change your diet prescription. Coming to my last case, which is 35-year-old young female diabetic hypertensive for 10 years but never controlled her sugars or pressures. And if you see now she has a height of 150, she has extreme weakness, the sight of food gives her nausea and vomiting. So if you have something like that and you see her biochemical parameters, probably again I think that the best thing is to prepare her for renal replacement therapy, whatever form she wants to go. So I think this is the right approach that we need to do, case based. Each person is different, so you need to modify and give your diet prescriptions accordingly. So the disturbances and variability of diet should be individualized for all patients, and I have just summarized into a standard diet prescription where the calories are adequate, protein you may decide depending upon the need of your patient, but yes, carbohydrates, since this is diabetic patient, probably 50 to 60% or probably in some cases going up to 70% of energy coming from carbohydrates, but complex carbohydrates is something that you really need to pay attention. So to summarize, diabetic kidney disease is preventable because Dr. Manish really showed us nicely that if you control your sugars, you will not have a problem. When detected early, it can be reversed, and if it cannot be reversed, then the progression can be controlled with proper dietary intervention, controlling the glycemic control, blood pressure control and dietary protein intake. And of course, the prescription has to be individualized. So as a nutritionist, we have a very challenging role, and I am sure all my colleagues sitting here, we fulfill it very well, where you not only talk about the diet, but you talk about overall health to the person. So this is all from my side. Thank you for your patient listening. Thank you.